So let's move on now for the very interesting, for me at least, medical legal aspects in ROP. How many of us are screening ROP babies? So there are a lot of people who are here who are looking into the babies. So my talk is not going to be didactic. These are actual cases that have happened. So we are going to learn from these cases what the court has decided. So it's like saying that we have the past question bank. So that's how we are going to answer the future questions. So most of us have done it. We have seen the question banks. We know the ideal answers. So we are going to learn those ideal answers from this. This has been the most sensational case of ROP till date in India. So this is a 30-weeker born in 1996. Why I have written down that we need to know that these babies grow and they are going to grow and remain there throughout our lives at least, because they are just born. So their lifespan is going to be more than ours. So ROP is filled, it's like walking on glass bottles, If you're going to do that, you have to be ready to face these litigations even after a long period of time. So this happened in a government hospital. This is also important. Initially, we were thinking that if we are doing it in a charitable place or a government hospital, we are exempt and it does not affect us. But this happened in the government hospital where neonatal experts and pediatricians did not warn the parents. The child developed stage 5 ROP, complete retinal detachment, blind for life. They went to the US and got the child operated at the best places 4 times. But nothing happened. So they came back and they filed under the Consumer Protection Act in February 1998. So what they wanted was just 20 lakhs towards airfare, medical expenses, 30 lakhs towards the future treatment and 50 lakhs for the pain. So they asked for 1 crore and the consumer protection gave them 5 lakhs. So if the consumer protection had said ki something around little bit more, no, they might have been satisfied at that point, but no. So they were awarded 5 lakhs, so they appealed in the Supreme Court. The Supreme Court ordered the state and other respondents to pay 1.38 crores as compensation and reimbursement of 42 lakhs, the total coming to a whopping 1.8 crores. So in 1996, this happened. The compensation they got in 2015, about 20 years later. So whatever we are doing today, you still have to remember that it can come back to bite you after 20 years when you have stopped your practice. So it's still possible. 32-weeker delivered by LSCS in a nursing home. The nursing home did not have NICU facilities. They shifted to a different NICU for 27 days where they were attended and followed in April, May and July. The mother noticed the white reflex in November. So till July, the child was followed up by ophthalmologist. And this is what the indoor notes show. So the date is written, seen by X doctor, no ROP, and review after 2 weeks, and they have signed. So what the court found, that the responsibility of recognition of infants for screening lies with the pediatrician and the neonatologist. So that helps us. So we are not directly involved. So they have to recognize that these babies can get ROP. So the pediatricians are involved. And ROP screening is a teamwork. You have to involve the pediatricians, you have to involve the ophthalmologists, you have to involve the personnel in the NICU. And most important, what they have said is there is no proper medical documentation. It is found that if you have to screen ROP, you have to use indirect ophthalmoscope, you have to dilate the pupils, and you have to depress the sclera. This is what the court wants. So if you have done it, it's wonderful. If you have not done it, at least write it on paper. So what was written on paper was this. Let's go back to this. So we don't want this. If you are writing this is a potential minefield. If anyone sees this, you are definitely going to get sued. So this hospital and the doctors had to pay 64 lakhs. 31-weeker in NICU for 5 weeks, screened at day 8. Ideally, we want to screen ROPs after 2 to 3 weeks, at least once before 1 month. and the child was diagnosed stage 5 ROP after 3 months of discharge. And in the discharge summary, it was not mentioned whether if any time ROP screening was done by them. So there was no mention of ROP screening. So which makes the screening date, whichever was mentioned over here, doubtful. And there was no mention of it at the time of discharge that the ROP was conducted by the doctors. No advice was given to the parents to get the child screened, and the necessity of regular screening was not explained to the patients. 7.5 lakhs compensation. 30-weeker NICU stay for 24 days, follow-up was done. ROP stage 5 was noticed after 4 months. Again, documentation was not adequate. Compensation of 5 lakhs. So these are last few years of all the compensations and the great and the amount of medico-legal cases done in India. What is happening now is that as we go down, you can see that now the ophthalmologists are also being involved. Initially, the court was giving a verdict and found the NICU, the hospital, the pediatricians liable. But now the ophthalmologists are also liable. So we have to be careful. So from all this, what gist do we get is that onus of screening lies with the pediatrician, the NICU, the hospital, whatever it is. So if they fail to produce the child to a ophthalmologist, if they don't get an ophthalmologist to screen the child, then it's their problem. So they are going to get sued, and who will be responsible is the MD or the dean of the hospital and the pediatric NICU department who is there. Co-liability may include the ophthalmologist if we have seen. Now suppose the screening has been done by an ophthalmologist, preferably a pediatric ophthalmologist, but there is no mention in any of the judgment that there has to be a trained pediatric ophthalmologist or a retinal specialist to screen the child. What they mention is that the person should be well versed with indirect ophthalmoscopy with sufficient expertise in staging ROP. You don't need to treat ROP also, you need to stage ROP. Finally, what it comes down is communication. We have seen in Dr. Ashish's talk also that most important aspect is communication. So once we have screened and once we have followed what the court wants us to do, we can still get sued. We may win the case, but then you're going to go to the court, you have to file legal documents, and all these hassles can be avoided if you update the parents continuously about the condition of the ROP. Many times when we go to the NICU, our timings are very different where the parents are not there. So make it a point to talk to the pediatrician or ask the nurse to call up the parents. So we had one child in the NICU, both the parents were working. So, and many times they have twins, triplets. One child is in the NICU, the other child has to be taken care of by the mother at home. So both the parents may not be there at NICU. So if it is possible, call the parents. It's very easy. So they have the numbers of the parents, you call them and update them. And explain the risk of poor visual outcome in the severe cases. And then document that you have spoken to the parents on the case sheet. We should have a protocol in the NICU for treating these patients. The criteria of how to screen should be well documented and defined. What happens is that after a few years, say 1 or 2 years, the pediatric NICU changes. There's a new NICU person coming in. Sometimes the nurses get rotated. So after 6 months, there are a fresh batch of nurses who do not know what to do. Once I went in, the nurse said the child is fully dilated. You go and see it's fully constricted, the pupil. What they have used is they have used paracaine to dilate the eyes. They do not know what is paracaine, they do not know what is tropic acid. And if the nurse has dilated, she has to write it on the indoor paper. Make sure that the nurse writes these things on the indoor paper, because the court goes through these papers, indoor papers, and they say that you have not dilated the patients because there is no mention of those drugs in the indoor paper. So the nurse has to give the drop and mention it on the indoor paper. So if in doubt, again, we are very clear about that, always go for a second opinion. Like Dr. Ashish said, try to give it, if possible, send them to an institute, if possible, to a senior ophthalmologist, document it that you have sent the patient for a second opinion, and if we are not equipped, you have to transfer it to an NSU that can treat ROP. So if you are a pediatrician, these are the things that you have to avoid. If you are an ophthalmologist, these are the things that you should do. That you should have sufficient knowledge in screening ROP, you should document the type of dilatation, type of examination and the follow-up, and refer if you are incapable of treating further. Having said all that, this is what I saw 1 month back. So all the chart, everything is very good, but what the doctor has documented is really quite bad. When you are saying that it is stage whatever, zone 3, there is overwriting on top of that, and then the patient was told that you need surgery for saving the eye. So these are all things which are very ambiguous. Even the mention of the stages, zones, we are not very sure what the child has got. So this is showing us that the doctor is not well versed in screening ROPs. So this is a potential landmine. Are there any questions regarding ROP? Yes.
It's not exactly regarding ROP. The question is parents. The word parent in today's world is, you may be a single parent. Do you want, when you're going to talk to them, you want the mother and the father?
Either or is okay, but you document that you have spoken to X.
Yeah, because I think that's very important. Because in today's world, mother or father, and then the word becomes parents. That itself becomes a potential, as you said, for. So they'll say, even not for. So that thought that is very important.
So once in our hospital, we had a baby where the baby was going to go for laser, and it had come from some other hospital with the baby's father. So everywhere it's done, and when they are signing it, baby's father has signed the consent form, and by mistake when he was talking to someone, he revealed to us that he is the mother's brother. So actually he is the mama. And till the screening and till the laser, we have not realized that he is not the father. So we have to be careful with all these things, but we have to take it at face value.
Is it mandatory to do screening in the NICU only? Because many a times we see them in the OPD. Okay, our ophthalmology OPD.
We can.
Okay, fine.
So there is no fixed rule that we have to see it in the NICU. Wherever you see it, you have to document it. That's all.